waiting for one of our speakers. So maybe Muskan, if you can try to call Sylvia, but we will get started. Um, and hopefully Sylvia will join very quick. Okay, welcome everyone to this exciting webinar. My name is Sanjay Saha. I'm the founder and CEO of B-Skill. This webinar is jointly organized by InSupply Health from Kenya and B-Skill. This would be about an hour and a half. This webinar will be an hour and a half long, and this is a CPD certified webinar. To get your CPD certificate, you would have to stay until the end. At the end, we will show you a QR code. You can scan that QR code and you will get your certificate right away. Okay. So the agenda for today, we will do a quick welcome and introductions of the speakers. We have already started introductions of all of you, so I'm very glad you're writing that on the chat. Then we will take you through the standardized forecasting and supply planning journey, the way it should be done. I'm sure many of you have been involved in forecasting and supply planning, or you may want to call it quantification. But still, we would like to go through the standardized process. Then we will go to the core part of this webinar, which is to understand the various challenges along the quantification process within forecasting, within supply planning, and beyond. Then, once we look at some of these challenges, we will look at first theoretically how to address those challenges. And then we will invite one of the speakers who, and I will talk about her very shortly, who is from Kenya, Ministry of Health. She will also talk about from a more practical perspective on how they have addressed some of these challenges within the quantification process. In between, there will be some polls, one at the beginning, one slightly at a later stage. And throughout the process, you can ask your questions on chat. Unfortunately, we would not have time for verbal questions. So make sure you're writing your questions on the chat. We will try our best to answer as many questions as possible. However, since this is being recorded, any questions that we are not able to answer, we will compile them and we will share a compiled Q&A document after the webinar. The last section of the webinar, we will also showcase a very practical and advanced certificate course on forecasting and supply planning, which is developed jointly by InSupply Health and B-Skilled. And we will showcase some of the feedback and we will invite you to join that course as well if you want to. So that's the agenda. Our speaker is here. So Sylvia, just want to do a mic and camera check. Can you hear me? And just want to check your camera. Are you visible to us as well? Excellent. Excellent.
Yes, thank you.
Okay, excellent. So we will come to you shortly. Just wanted to make sure that
Okay.
we can hear you well.
Okay.
So some of the housekeeping guidelines, I've talked about it briefly. But just to reiterate again, you can use the chat box to share your questions, your experiences, or any comments that you want to. Right now, anyone who's joining, please write a quick introduction on the chat as you see everyone doing that. During this webinar, there will be several polls where we will create a think and respond moment for you. Like I said, we will be able to share a compiled Q&A document after the webinar. Anything that we are not able to respond to during the allocated time. This is a CPD certified webinar. A QR code will be shown at the end. So you have to stay until the end if you want a certificate. We will not give you certificate. You have just spent like 5 minutes. So stay until the end. And once you complete a small form through that QR code, you will automatically receive a CPD certified certificate with your name. So for today, we have three speakers, and I will also request Dr. Gathi to be on camera just for this segment, at least for now. Uh, First of all, it's of course myself. I will introduce myself a bit later. Then we have Miss Sylvia Savai. She is the Supply Chain Transformation Manager at InSupply Health. Sylvia, a quick introduction of yourself.
Uh, Thank you so much, Sanjay. So, as you introduced me, I'm Sylvia. I work within Supply Health, a pharmacist by training, based in Tanzania, and been doing demand planning. So happy to be here. Thank you.
Thank you so much, Sylvia. We also have Dr. Eunice Gathitu. She is from the Directorate of Health Products and Technologies Department within the Ministry of Health of Kenya. And she is an expert in supply chain and also has led several quantification exercises within the country. Dr. Eunice, a quick introduction from yourself.
Thank you, Sanjay, and good morning, good afternoon. I know people are at different time zones. So my name is Dr. Eunice Gadido. I am a pharmacist by training and currently working at policy level in the Ministry of Health in Kenya. So I have some presentation a bit later. I'll take you through our experience as a country. Thank you.
Thank you, Dr. Gathitu, and you're very modest. You have done quite a lot of work within Kenya, and I sincerely believe that everyone will benefit from your experience. And finally, I will be facilitating and supporting these two expert speakers from Kenya. I'm the odd one out. Would love to have more female speakers in future, but for now, you have to content with me. So I have about a decade and a half of experience in health systems strengthening. I started from India and worked a lot within Africa in areas of supply chain, pharmaceutical regulatory, health programs, so on and so forth. In the last 5 years, I have been leading Be Skilled, where we focus on developing and delivering affordable yet high quality e-learning programs for health professionals, health and supply chain professionals within emerging markets, focused on Africa, of course. This webinar will be facilitated and moderated by me. I will make sure that any questions that you're asking on chat, either I respond to you on chat directly or I ask those questions to our speakers. Now, without further ado, I would invite Sylvia to take the next sections. Sylvia, I have the slide control, so anytime you want to move, you can just say next. You have about 40 minutes for your section, and then we will go to Dr. Gathitu's section. Over to you, Sylvia.
Thank you so much, Sanjay. Thank you for the introduction. It's a pleasure for me to be here. As Sanjay said, I'll start off the webinar by taking us through the forecasting and supply planning journey. And then I'll briefly talk about the challenges that we see while we are doing the quantification process before inviting Dr. Eunice to share the case study. So as we are talking about this journey, I would like us to start off by thinking about Greenville. We'll start with an example, but it could not be Greenville. If we have people from Nigeria, it could be Kano, it could be Bukoba. Depending on your country, it could be Jinja if in Uganda. Just assume you are part of the quantification team and you are going to do a quantification for a measles vaccine. So the district team or district quantification team from Greenville was preparing for a forecasting exercise, and they had data that showed that they have 10,000 children aged 9 to 12 months. And these are the children that required the measles vaccine. Each child was to have 1 dose of the vaccine per year. Unfortunately, the team had a lot of pressure, all was under time pressure. So they quickly reviewed the last year's consumption and placed an order. That is all they did. So before we proceed to the next slide, I would just like us a rhetorical question. If you are part of the team, do you think you did the right thing, or was that the right process to follow? And what would you have done differently? Or what do you do differently in your workplace? Next slide, please, Sanjay. So we see 6 months down the line, the situation in Greenville is not good. They have stock imbalances. There are facilities that have already run out of the measles vaccine, but at the same time, there are facilities that are overstocked. They are not able to do their outreach services, and caregivers are told to come back the next time. So that means there is a lot of distraction at the service delivery level. At the last mile, there's a lot of service delivery disruption. So what do we take from this as we move to the next slide? The district team did a root cause analysis, and what they came to realize was the target population had grown. They had assumed the children that they had the previous year are the same children that they are having this year, which is not the case. They had not accounted for wastage, and in this case, they had higher wastages. That's why some health facilities were facing stockouts. They had also not planned for mop-up campaigns. And from this example, we get to learn one thing. We learned that whatever happened to Greenville could happen to any of us, to any of our districts, to any of our health facilities. And why is this? Because it's not enough to have data. You may have data. Greenville had data about their consumption. They had data about the previous year consumption. They had data about the number of children, the demographic, but they did not analyze this data. Having data is not enough. You have to analyze the data, clean it, look for outliers, see the trends, and then use that data to make a forecast. They also used one set of data. They used one set of data and they used only 1 year of data. So it's always important to use more. And they did not do supply planning. If they had planned their supplies, their shipments, and done continuous pipeline monitoring, maybe 3 months down the line, they would have noticed that they have challenges and they could have expedited some shipments, but they just placed an order. We are not sure if it was one single order or it was different orders, given that different children meet the age throughout the year. So these are some of the challenges that you see when we do not walk the quantification journey. If you just decide to do quantification as a single process, a single step, you'll face challenges. Your problems may be more catastrophic than what happened in Greenville. Next slide, please. So I'll now take us briefly through the forecasting and supply planning journey. We see that this is a journey that has about 3 to 4 steps. There is some literature that takes it as 3 steps, but we decided to put 4 steps here, breaking the forecasting bit into 2 steps. So we have the first step, which is the preparatory and design of the quantification, which is the first step. The second and third steps are concerned with forecasting. So the second step is building the forecast. The third step is where we reconcile and finalize the forecast. And finally, the fourth step, we develop and monitor the supply plan. So we'll go a little bit in detail in these steps. We'll start with the preparatory step. So while training or sharing, I usually share the importance of the preparatory step. So for everything we do, for women, I usually say, if you are going to cook, you want your food to be delicious, you have to prepare the ingredients. If you are going to just start cooking without preparing ingredients, you will have a food that is non-delicious. If you're a gentleman and you are planning to go on a trip, you have to prepare your vehicle. You need to service it, you need to fuel it. These are things that you cannot just start driving off. If you just start driving off, you may end up getting a car breakdown. So when we come to the health sector and forecasting or preparing for forecasting, in the first step, this is where we'll determine which program we are going to forecast for, or which program we are going to do the quantification for. I'll take an example of the HIV program. Many of our countries have HIV programs. So you look at, I am going to do quantification for the HIV program. Which commodities? Am I going to cover only pharmaceuticals, or am I going to include pharmaceuticals and lab commodities? Then you look at the duration. Am I going to forecast for 1 year? Am I going to forecast for 3 years? Am I going to forecast for 5 years? Because long-term forecasts are good also for planning purposes. So this is where you will clarify before starting. It's not in the middle of the quantification that you're saying, no, we need 5-year forecasts, yet you have drawn assumptions for 1 year forecasts. At the same time, this is where you'll have clear roles and responsibilities. It's always important to have who is going to be part of the team. This is the place where you are preparing, for example, for the forecasting workshop. You do all that preliminary work. Who is going to be part of the workshop? We have all the right people in the room. You are not going to do it alone as a logistics person. You need program level staff that will tell us what is happening at the health facility level. You need procurement staff because you are going to do the supply plan and they will be there. Sometimes you're a logistics person, but you're not very good. There is a lot of data involved. You may need data analysts that will do the analysis for you. So this is where you'll do all that in the preparatory stage. And finally, you now determine which types of data you have. You look at, do I have service data? Do I have logistics data? Do I have demographic data or mobility data? And all this data that you have, you also have to find the source. Okay, I have it. Is it already compiled? Is it at the health facility level? Is it in an electronic format? Is it in a format that is paper-based and will need some manual work to compile? All these are done during the preparatory stage. Next slide, please. Thank you. So after we have collected the data, we will now proceed to the next step, which is the forecasting part, or building the forecast. And we'll start off by organizing and analyzing the data. So you see, we have used various sources of data. You may have consumption, you may have demographic, you may have issues, all these types of data. You have to organize them and then review them, look at them for outliers. For example, when I give an example of spotting an outlier, we'll still move with the HIV program so that I don't go back and forth. We'll move with the HIV program here. If it's an HIV program and you see each health facility serves a population, a certain population, depending on the catchment area. If you see, for example, for TLD, a dispensary has reported a consumption of 10,000, yet the district hospital or the health center has reported a consumption of 2,000. And you know, by average, the health center or the dispensary always has lower consumptions than the dispensary. You'll have to look at it and say, is this true? Is it really true that this dispensary served 10,000 clients with TLD? That may not be the case unless there was a special circumstance. But because these clients are known, you will assume it's an error. Maybe the healthcare provider put an extra zero. It was just a data entry error. So this is what we mean when we say we spot outliers. But you also have to identify periods of stockouts. And once you have identified these periods, then you adjust for the stockouts. You don't just assume it was zero, because then if you do the forecast with a zero consumption, yet it was a stock out, that means you'll get lower numbers in the next years. After organizing your data, analyzing it, adjusting it, you now develop assumptions. These assumptions can be anything. And one thing to note, when we are developing assumptions, it's always important to document them. First of all, make the assumptions realistic. Don't assume you have always been having a coverage rate of 60% for the past 4 years, and now you are saying you are going to have a coverage rate of 90%, you'll end up having wastages. If you are going to have 90%, there should be something. Maybe you have another facility that has been built, or you are going to run campaigns. We are not saying you cannot increase, but what I'm trying to say is make your assumptions realistic. And assumptions can range from population growth. They can also be about changes in the treatment guidelines. For example, a new medication is going to be introduced, changes in government policies. For example, if a country was allowing public-private partnership and now they're saying all certain services will be done in public facilities. In that case, then you have to assume that more people visit the public facilities. And finally, you now select the forecasting method based on the type of data you have. So this is where we also have to use different tools. You may decide we'll still continue with the HIV or donor-supported programs. You may decide to use tools like the quantification analytics tool that is used in various countries, depending on the type of data you have. But sometimes you may use tools for essential commodities, for example, the bottom-up quantification, or you may use simple Excel sheets. It does not matter. What matters is you have done your assumptions. Of course, using the modern tools is easy. It saves time. But we are not saying if you don't have a specific tool, don't do the forecasting. No, you can still use forecasting. You can still do forecasting using simple tools such as Excel sheets, provided you make clear assumptions, document your assumptions, and do not use methods that are not appropriate for the type of data you have. For example, here I'll give an example. You are doing forecasting for a malaria program, and you know malaria, there is some seasonality to it. When it's the rainy season, you have higher incidences. All for cholera, when it's raining, there's an outbreak, or trachoma. So use a tool that would allow input of seasonality. Do not just go for the complicated tool, oh, this is a new tool used by this program. Even the tool that you use or the method has to align with the type of data you have, or what you have planned to use, the model of forecasting you'll use. Next slide, please. Now, the third slide is about reconciling and finalizing the forecast. It's always a best practice to use various sources of data. So if we were Greenville, we could have used consumption, we could have also used the demographic data. So depending on the types of data you may have, you can develop different forecasts. So you can develop forecasts using consumption data, or using demographic data, or using mobility data. And then later you can try to align. This is where now you will usually hear people say quantification is an art and science, or forecasting is an art and science. We believe whatever we are saying cannot be 100% correct, but we try to find something that is the best match for what we plan to do. So this is where you look at the data you have. So you start by reviewing the quality of the data. If I used my consumption data, do I trust its quality? Am I more conversant or happier with the demographic data? Then you can look at the output and decide which output to go for. Sometimes it's not easy, or it's not possible to choose, and you could decide to average all of them. That's also applicable. It depends on now the knowledge of people who are in the room, the historical trends. Is this telling us the story as per our past, or is this telling the story we want to see? So comparing the past and looking at what you want to see, then you can reconcile and finalize the forecast. But it's also important to validate the numbers. As a quantification team, after you have come up with the forecasting results, it's always important to call a larger audience. So this is where you now call the donors, staff from the health facilities, officials from the Ministry of Health that were not part of the team. Then you share the forecasting results with them. This is where they'll look at the numbers, and if all are in agreement, then you could proceed with the next step. But if all are not in agreement, then you can go back, adjust some assumptions, and make changes. Next slide, please. And finally, as we are walking the quantification journey, the final step is the development and monitoring of the supply plan. So after we have the forecasting output, after we have the quantities that we need of the commodities, we'll now create a supply plan. And as we are talking about using data, we also need data for this. We need inventory data. How much do we have? We may need 10,000 vials of the measles vaccine, but if we already have 5,000, that means we only have to procure 5,000. If we have no stock, that means we will have to procure the entire 10,000. But we also have to consider what is incoming shipments. If I need 10,000 vials of the measles vaccine for Greenville and already 3,000 down the way, that means I don't have to order all the 10,000 unless I'm sure I'll use them. So we'll consider various parameters as we are developing the supply plan. We have to consider the min-max levels for each individual country. So this may vary. You may have a different min-max for the central level and the min-max for the health facility level, which will give you the national min-max. We also have to look at our warehouse capacity. This is a very important thing because sometimes we get wastage from commodities because they will come and there's no space in the warehouse. They're just outside or they are squashed waiting for space. So we also have to consider warehouse capacity in the cases of commodities that require cold chain maintenance. We also have to take that into account. We have enough vehicles for transportation. We have enough facilities for storage. Are we having power shortages? The other thing to consider is funds. So when you are developing your supply plan, you'll also have to consider funds. Funds are always a challenge. Resources are limited everywhere. They are more limited in the health sector. Our governments try, but it's not always enough. So in this case, you'll have to prioritize. You can decide there are different ways you could prioritize. You could prioritize based on the vital, essential, and non-essential commodities. For example, the VEN, you decide that with the available funds, we'll make sure we start with procuring the vital commodities, or you could procure the fast-moving things that are fast-moving. But sometimes it's just knowledge. What can I say? You could decide that we are coming to a season of malaria, for example. It's important for us to have this. And there are things that are life-saving. Taking an example of the HIV program, we usually say you'll have nevirapine at every health facility. Even if it's not used the whole year, but because it's life-saving, you decide you want to prevent mother-to-child transmission, so every health facility has to have that in case there's someone that will require it. After you have drawn your supply plan, you now have to continuously monitor the pipeline. This is where you'll start looking at, is the forecast aligning with the actual consumption? Do I have a lot of stock in country or at the warehouses if you are doing local procurement? If you have too much stock, then you will decide, no, I now do not need to order more, and decide to push some shipments. If you see you are running out of stock, you can then decide to expedite some shipments. If shipments were coming by ship, you could ask that they come by air. If you were ordering from an international supplier, you could decide to procure it local. So this continuous monitoring of the supply plan ensures that we are always having availability. Remember, as we are doing quantification, it's not just for the sake of quantification. Our ultimate goal is commodity availability at the service delivery level. We want every patient to get the medication they require. It's not good if they have to start looking for it somewhere. And as we are monitoring the supply plan, we are also tracking our forecast accuracy. So there are different ways you could do this. You could do the MAPE, you could do the MAD. We will get to see this as Sanjay will talk about in the course. Thank you. Next slide, please. Okay. So after we have seen the quantification journey, we know that it has some challenges. Many of us have done quantification, or even if we have not done quantification specifically, we are working in the supply chain space, and we know that there are challenges. So we'll talk about the challenges in general before we come up with some solutions. Thank you, Sanjay. When we look at quantification, our greatest challenge is usually data. The first challenge is data. We may have very many challenges that are associated with data. For example, we may have data that is missing or incomplete data. You have health facilities. I'll take an example of Tanzania where I'm familiar. You have 8,000 health facilities in the public sector, but only 5,000 have reported. That means the consumption you are seeing, the national consumption you are seeing, is not a true picture. We also have data quality challenges. Sometimes our healthcare providers, whether by error or by having too much, may report data that is unrealistic. And you may find that you have data that does not align. You have HMIS, you have data in the DHIS tool, is not aligning to data that is in the logistics system. So you are wondering, was there an over-reporting in the DHIS tool and under-reporting in the logistics system, or vice versa? And sometimes we have data that is outdated. You are looking for data for a program, but the most current data you have is 4 years ago. A lot could have changed in 4 years, so it may not be really realistic to use that type of data. That's why we say it's important to have different types of data. But we still have countries or programs where we are using paper-based data collection. So if you have paper-based data collection, definitely the data collection exercise is going to be cumbersome. It will take a lot of time. It will have a lot of errors. There will be a lot of missing data because now some papers have been thrown away, or handwriting is not easy to read. There are a lot of challenges associated with the paper-based data coding. We also have funding challenges. We have the most common that I think everyone can relate to is, for example, for the donor-funded programs, where the USAID government decided they are going to stop funding some of the programs, such as family planning. So if this was already not budgeted for, then it is a challenge to get money for the procurement of family planning commodities. But even for essential commodities where the government is doing the procurement, funds are always limited. It's not that the money allocated will cover 100% of the costs. So that's why there's always a need to prioritize. We also see that we have challenges with human resource. Human resources are not enough. For those that are there, we may not have enough quantification skills. And here I would like to applaud all of us attending the webinar for taking it upon ourselves to improve our quantification skills. So kudos for that. But we may have people with skills and unclear roles. That's why we said we need to have a clear quantification team with clear roles. And last but not least, it is difficult to analyze forecast accuracy for some programs. And this may go back to the data issues. If we are not able to analyze the forecast accuracy, that means we are not able to improve. We need to see where we can improve. Are we doing something right? Is there where we could make changes? But there are also some challenges that are related to supply planning. You may have, given that most of the procurement in sub-Saharan Africa or African countries in general is from other countries, we usually have some shipment delays. And this is sometimes not in your control. If, for example, there is a war or there is a natural disaster, then this is something you could not control. But it is still a challenge. That's why we always try to mitigate it. So I think I'll pause there and give us a chance to go to the poll. Thank you. Should I continue or we are going to the poll?
No, sorry, we have a poll. Yes, it was by mistake. So thank you so much, Sylvia, for this section. And I would request Muskan to launch the poll. So far you have heard Sylvia talk about the process of quantification and some of the key challenges. On your screen, there is a poll where we would like to hear from you. What is the biggest challenge that you see within quantification? And you have multiple options. Please choose only one option that you feel is the biggest challenge today for you within the quantification process. Um, I would also like to add to what Sylvia has been talking about while, of course, you are going through this poll. Um, Sylvia talked about a lot of processes in those 4 steps. And you may be thinking that you are following some of them and you are probably not following some of them. Um, and it is very important to understand that quantification can be a very long process, and hence you have to be prepared much in advance. You cannot think that, okay, I need to do a regional or a national quantification and I need my products 3 months down the line. Well, that would not be quantification. That would be something else. Quantification seriously would take time. And when we invite our next speaker, she will also talk about the time factor here. So, probably, Sylvia, you would agree that a key challenge that, although we have not noted it explicitly, is failure to understand the time that it should take to do a proper quantification process. And it is very important for everyone to understand that if you want your product at a particular start arrive, like products must start arriving on a particular day or a particular month, depending on the situation of your country, you may start thinking about that quantification probably 12 months in advance, if not more. Sylvia, any comments on the time factor as the poll is ongoing?
Yes. Thank you, Sanjay, for that wonderful addition. Time is a factor, and sometimes for the teams that are not doing quantification, for example, they may wonder, what are you doing? What are you doing for 4 weeks? And in addition to the 4 weeks where you'll have the hands-on, you need to still monitor the pipeline, maybe on a bi-monthly basis or on a quarterly basis. So someone may wonder, demand planners, you are always doing something. You are handling, for example, demand planners for a particular program. Someone is a demand planner for malaria. They may have 6 commodities, but all the time they are always busy doing something. Someone may not understand, but it really takes time because all those steps have to be followed. And the end of one activity is the start of another. So you are done with the workshop, you now start collecting information, you start collecting data. You need that data to review your accuracy and for the next quantification. Thank you, Sanjay.
Yes, excellent. Muskan, if majority of people have gone through the poll, maybe you can stop it and share the results. Excellent. So the results on your screen. Muskan, do you know how many people participated?
65 people
Okay,
participated.
excellent. So
Yeah.
that's an excellent number.
Yeah.
So as we can see, the biggest challenge that people have noted down is ensuring the data quality. And I think, Sylvia, we talk about that quite a lot. Data quality is a key issue. Then on number two, I think it's having enough skilled staff for forecasting and data analysis. And then on number three is the identification and the accessibility of relevant data sources. So I think, Sylvia, what we have been talking about, and I think the way we have designed the course as well, I think we talk about these three issues quite a lot. And then I will give it back to you for your final segment before we invite Dr. Gathitu, and you can talk about some of these results as well. Back to you, Sylvia.
Thank you so much, Sanjay, and thank you to everyone for participating in the poll. Uh, we would have been surprised if data had not come out as a key challenge, because that is what we observe. I'll now briefly take us through the strategies that we could use to resolve some of the challenges. And as for everything that I've said before, this may not be exhaustive, but you'll find more examples in the forecasting and supply planning course if you decide to take it. So we'll start with challenges that are related to data. If we could move to the next slide, please. Okay. I may have alluded to this while I was speaking previously, when we are talking about data and we are wondering how are we going to do this. So we can make our data usable. As we said, this is what we would say data cleaning. You would, for example, adjust for outliers. We already said that. And in cases where you may not have data, there are times where there is missing data. If it's you are forecasting for a new program, you are forecasting for a new health facility, then you can decide to use proxy data. You can decide if this is a dispensary in the same catchment area or in the same district. I would expect it sees the same number of patients as a similar dispensary in a similar rural area. So you could use numbers for that dispensary to the other dispensary. But there are times where you just have to neglect the data. That's also a solution. For example, if you have data from 10 years ago, you cannot use that data. You need to just disregard that data and find alternate sources of data. So we could adjust for missing. We could also adjust for outliers, but we can also use proxy data as we are trying to make data usable. Next slide, please. This is related to the other, and this is where we are trying to correct, for example, incomplete reporting.
Sorry about the slides. I don't know. It just moved. You carry on, Sylvia.
Yeah, right there. Yes. So if we have incomplete reporting, sometimes you can decide to do percent reporting. I'll take an example of maybe Nigeria. If you have 25 states and you now have data from 30 states, you have 25 states and you have data from 20 states. That means you do not have data from 5 states. You can decide to make a percent that if I am having maybe these 20 states are 80%, if 80% is giving me a consumption of 1,000, what would be the consumption if all states reported? So what would be the 100% consumption? So you could fill gaps by doing that, by doing the percent reporting or looking at volume-based. One key thing that we should avoid is avoid using zero or zeroing out non-reporting. If there is no reporting, please adjust. Do not assume it was a zero consumption, for example, or do not assume it was a zero patient treated that month just because they did not report. If they truly did not treat, that's okay, but we should avoid using all zeroing out consumptions or that are not reported, or out of stocks that are not reported. So we always have to correct that. Next slide, please.
Sylvia, just before you start, you have about 5 minutes. Thank you.
Oh, you said 15. Okay,
Sorry.
thank you. I'll finalize. So using the right method for the right data, I alluded to this at the beginning. So you make sure you are using the simplest forms. I always warn against using complicated, especially if you do not have enough skilled people. So use the available data with the right method. If you have logistics data, please do consumption. If logistics data is missing, you could replace it with issues. If you have demographic data, use demographic forecasting, and so on and so forth. But also consider the quality of the data that you have. Next slide, please. We talked about assumptions. We should make assumptions realistic, clear, and they should be documented. So when you are recording assumptions on data gaps or program performance, this will help you look at what the data is telling and what is happening in future. This is also important in case there is task shifting. You may leave your role, someone else does the quantification next time, they have something to refer to. They can get to understand where the numbers came from. If you do not document your assumptions, and if your assumptions are not clear, that means you cannot replicate the process. You cannot do it again next year. Every time you'll be starting from start. And then that's where we are saying it takes time. Yes, it takes time. But if you have assumptions and you have documented and they are clear, they are realistic, then the next time you are able to decide, this, I assumed this last time, it did not work. So clearly this is not working. Let me make a different assumption. And assumption should be part of the main method. It's not a by the way that later the numbers are not adding up and you're saying, maybe we assume we reduce. No, it should be part of the process and the time should be allocated for it. Next slide, please. Strengthening people and processes is the final part of the strategies we'll use today. Strengthening processes, you have to have a clear timetable or calendar. You have a quantification calendar. For example, you do quantification every March. So it is known March of every year you are doing a quantification and everyone adheres to the calendar. You have a quantification review. You set time for a quantification review. Maybe 6 months down the line, you'll get to review your quantification. So that is strengthening the process and a clear process flow. So 3 weeks before going to attend the workshop, we'll collect the data and then we'll have the workshop. After forecasting, we'll have a consensus meeting. So it's a process. It's not on someone feels like doing it and they do it. The process is documented. There are clear SOPs. The SOPs would also be important in case where we have task shifting or new employees. Someone is new to the role at a dispensary. There is a clear SOP. There is a clear guideline. For example, they'll have the BOQ guideline. This is what I am going to do if I need to do a bottom-up quantification. This is what I am going to do if I need to do forecasting for maybe HIV commodities or TB commodities. For TPT, this is the process to follow. But then also strengthening people. This is where you'll have strengthening of people through training. You can have the physical training, but you can also have the virtual trainings organized by your organizations, your offices. But you could decide to take it upon yourself and do online trainings just like this that you are attending, where you are getting to learn skills for forecasting and supply planning. So we have to build the skills of different people, and we have to ensure that everyone is clear on their roles and responsibilities. We use the RACI matrix, where it's clear who is responsible for a particular function, who is accountable and has to be answerable, who is going to be consulted, and who is to be informed. So I think I was doing it very fast because of time. Thank you for your time, and over to you, Sanjay.
Excellent. Sylvia, first of all, thank you so much. Round of applause for Sylvia. There is a reaction button over there. So you can use this reaction button, for example, just to applaud for Sylvia. Yes, I see a lot of people applauding. Excellent. Sylvia, it was great hearing from your experience. You have touched upon various important issues, and you've created a great segue for me to invite Dr. Gathitu, who will now sorry, who will now talk about the same thing. We are still on challenges in quantification, how to move beyond those challenges, but now we will look at more from a practical perspective and something that has been implemented at a country level. So please give a round of applause and invite, as I invite Dr. Yunus Gathitu. Dr. Gathitu.
Thank you, Sanjay, and thank you, Sylvia, for that foundation. It will make my presentation easier. So, good afternoon once again. So I'll share our experience in the Ministry of Health in Kenya on forecasting and supply planning and work we have done. So in terms of background, when you look at Kenya, for us at the directorate, we are tasked to develop policies that touch on health products and to support counties, which are our subnational levels. So in Kenya, we have 47 county governments. And for us as national level, our mandate based on our constitution is on matters of policy development and technical assistance to the counties. So we have five main strategic programs in the Ministry of Health. There's HIV, TB, malaria, vaccines, and family planning and reproductive health. So those five programs usually do annual forecasting and quantification for their products. But for the non-program health products, it's not done as regularly. So the last one we did as a team was in 2021 calendar year. And we were able to extrapolate for 2 other years, assuming that we'll have a 10% increase per year on the requirements for health products. So we did it for all 47 counties and our 6 national referral hospitals. The categories we looked at were 8: medicines, medical supplies, lab, nutrition, radiology, dental, eye, and renal supplies. And one of the things that were identified in our HPT supply chain strategy that was 2020 to 2025 was lack of a national data for forecasting and quantification for HPT. So it was one of the gaps that we identified when we were doing the strategy, and we tasked ourselves as a team to conduct one in the lifetime of the supply chain strategy. And we know that as a country, we need to know our health products requirements, even as we work towards achievement of universal health coverage. Again, the other thing with forecasting data is that it helps to support planning and decision making, and that is both at the national level and at the county level where service delivery is being undertaken. Next slide. So the objectives for our national exercise, F&Q exercise, as I said, we did it in 2021, wanted to determine what are our HPT requirements for the country, for both counties and the national referral hospitals. So we did it for 3 financial years. Our financial year runs from July of one year to July of the next year. So we did it for 2021, 2022 to 2023, 2024. So as I said, we did it in 2021 and extrapolated for the 2 subsequent years. And then we also to look at the FNQ reports for the strategic health programs, the 5 of them. So we looked at their current FNQ reports for that time, and we didn't have to redo for their commodities, but we looked at their FNQ reports. Then the other objective was to aggregate the requirements. As I said, we aggregated county and data and the national referral hospitals. And then the fourth objective was to build capacity of the constituted quantification teams, because we wanted this to be a regular activity for non-program commodities for the whole country. Next slide. So the challenges, and Sylvia has mentioned some of them: the issue of poor record keeping or lack of stock records in health facilities. Many times you find medicines have good records, but the other health products do not have. Again, given the issue of capacity in terms of human resource, etc. Lack of pharmaceutical human resource at primary care levels. So those are the level 2 and 3 facilities. In Kenya, we have 6 levels of healthcare service delivery. So you find at the lower levels, we don't have pharmacists or pharmaceutical technologists. So you find it's mostly nurses managing commodities and the inventory. But again, given the training and the capacity, that sometimes becomes a challenge at the lower level facilities. The knowledge gap on commodity management. Pharmacists are very well versed on matters of inventory management, but other cadres that is not so strong in the pre-service training. So it creates a problem in the documentation and the management of inventory at the lower levels. Issues of inadequate storage facilities and poor storage practices. So we know in many of the primary care facilities, there are stores there, but they are not adequate. Some are not built to be stores, so it becomes just a room where products are kept, and that has been a challenge that we have had as a country. Then lack of a country price reference for HPT, and I'll mention when I'm talking about the methodology. So you find we have a national procurement entity for public sector called KEMSA, but counties have other suppliers. So when we were doing the quantification, at some point we had issues on what price do we use to guide the quantification. So that has been a challenge. Then inadequate digitization for inventory management. So a lot of the exercise was very laborious, a lot of retrieval of manual bin cards. Some were missing, some are not up to date. So of course, the low digitization can create a challenge in data retrieval and other aspects of forecasting. Next slide. So in terms of methodology, so at the time we were a division within the Ministry of Health, and we were able to work with an implementing partner that helped to finance the forecasting. And then we had a quantification team formed at each county level and for each national referral hospital, with us supporting from the policy level. So in terms of the data collection, given the time and financial constraints, we are not able to collect data from all facilities. And at the time, as I mentioned, in 2021, there were 21 counties that had recent forecasts that were less than 2 years. So we didn't have to do data collection again in those counties. So what we did is that we adjusted based on their recent forecast using their workload data for the previous year. But for 26 counties, there was data collection that was done. What we did is that we sampled again, given time and financial constraints. And what we agreed is that for the counties, in all the sub-counties, we had a census for all hospitals. What we sampled were the primary care facilities, so health centers and dispensaries. And what we did for every sub-county, we picked 2 health centers and 2 dispensaries. We looked at their workload for the previous year, so we picked 2 health centers and dispensaries with high and low workload, and we were able to extrapolate for the remaining facilities in those sub-counties based on their annual workload. And then the facilities we identified for data collection, we made sure that the criteria we used was that they have a wide range of health services that they're offering, and they had good data documentation practices, because that may speak to having better quality data. And the facilities picked was a consultation between the national government and the county governments, because at the county level, remember, as I mentioned, counties are tasked with service delivery. So the county teams know their facilities, and they were able to guide what facilities to target for the data collection. Next slide. And then in terms of the team, what we agreed is that the team comprised of the commodity managers from the county level and at the sub-county level. So what we consider based on the categories we said, so the core team was a pharmacist, a nurse, a lab, and a nutrition officer from the sub-county level, with support from the county and national level, so that every commodity manager handles their products, because there are unique parameters that may be relevant for certain HPT categories. And then there was a prior training done in consultation with the county team, as I said, to identify facilities for data collection. And of course, the team was guided before the data collection happened. We did data collection for 5 days. Data collection was done for 12 months, but that was not feasible, either due to stockouts or lack of documentation data. We looked at least data for 3 months, where there was relatively adequate stocks, because when there are stockouts, then you're not able to know what the true consumption would have been. Then our data sources were mostly stock cards, either manual or electronic, daily activity registers depending on the product, monthly summary reports, etc. And then morbidity data was used to triangulate for periods of prolonged stockout periods. But mostly it was consumption data that we were focusing on. Next slide. Then once we did the data collection, we had aggregation workshops to review the data, clean and forecast projections. So that's where, as Sylvia mentioned, you need to look at, are there outliers? Is there data that is missing, so that you make a decision of what would be the alternative to address any data gaps. And then within these aggregation workshops also, the teams were able to forecast to extrapolate for the facilities that data collection did not happen. So we're able to do that, a cluster of counties per workshop. And then, as I mentioned, the extrapolation was done for data where data was not collected based on workload. For any new facilities, we looked at proxy data for similar level of facilities within the county. And then for the national level, for the national referral hospitals, there was a separate aggregation workshop that we led, because remember, for the national referral hospitals, the needs, the services, the data, and the scope is very different from the counties. So we're able to do that. Next slide. So some of the assumptions, and these were discussed before even the data collection, and some came in when we had the aggregation workshops. So there are quite a number. So one was that the consumption of HPT would remain unchanged for the period that we were looking at. The other assumption was that the supply of HPT was timely once procurement process was initiated. Of course, that is an ideal situation. It doesn't mean that when you order, you receive during the period that you anticipate, but that was one of the assumptions we made. As I said, we looked at all hospitals in the data collection. We didn't sample those because hospitals don't give the same level of service. And remember, their catchment population is not static. So we were able to collect data from all the hospitals that for the counties that we were able to visit. Then, as I said, for dispensaries and health centers we sampled, we had a criteria for the workload. We looked at high and low workload for the counties that were visited, and were able to extrapolate for other facilities per level. So of course, you extrapolate for a health center with data from a health center, and for a dispensary with data from a dispensary. Sample facilities, as I've said, represented a specific level of care. The issue of adequate facilities with adequate capacity to store HPT. The other assumption was that we assumed that facilities have adequate capacity to store what they procure or acquire. Strategic health program HPT are availed by the national government, so we didn't do forecasting and quantification for strategic program commodities. We included a buffer stock of 3 months in the forecast. Then we assume that delivery of health products is to the last mile. So basically from KEMSA delivers to last mile, meaning to facility level. So that was the assumption we made for the facilities. Then the resupply, we assumed the resupply cycle is quarterly, but sometimes that is not always the case, but that was the assumption. We looked at the KEMSA prices for the exercise at the time, based on what they supply. Then we also looked at any non-listed HPT. Any non-listed HPT added would be validated by the county team. So what we did is that we had a product list that we used. Anything outside the list, the data was collected, but validation done during the aggregation workshops. Then for any missing facility data, we said we were to use proxy data from a similar facility with relatable workload. Then, as I'd mentioned, if any consumption data was missing or there were prolonged stockouts, we used other data sources like morbidity data just to fill in the gap for data. And then the inflation and other economic indicators would be constant during the financial year. And we assumed that for the 2 years we extrapolated for, we looked at a 10% increment for the needs per year. Thank you. Next slide. So in terms of quantification results, as I said, we aggregated data from our national referral hospitals that are 6, 47 counties, and the 5 strategic programs, as I'd mentioned earlier. Then for counties, the quantities and the financial requirements for the 8 HPT categories were disaggregated for each of the county. The national referral hospitals, we didn't have a standard tool for them because each of them gives different services. Some are similar, but some are different. So what we did is that we looked at the national referral hospitals as standalone for the products that they procure. We included a 3-month buffer for all products. We didn't adjust the requirements for what stocks were held at the time of the data collection or the pipeline quantities, because that is usually done during supply and procurement planning. Then in terms of data collection, we collected data from 826 health facilities. Most of them were public, 813. Then there were 9 faith-based and 4 private facilities. Data extrapolation was done for 6,349 facilities. Again, most of them being public, a number being faith-based, private, and 1 NGO. Next slide. Then in terms of our analysis from the financial requirements that are required per category, as I said, the categories were 8. And we did a breakdown of that, looking at the county and the national referral hospital proportion, of course, totaling it up to what the national picture should look at. So maybe just a highlight if we look at the county proportion, the biggest proportion is for medicines, then medical supplies, lab, and nutrition. So those 4 categories were taking up about 85% of the financial requirements. But for national referral hospitals, the bigger proportion was for medical supplies. So medical supplies and medicines take up about 80% of the requirements. But now when you look at the total proportion, again, medicines take up the majority, with the other categories being lower. But of course, that gave us a picture at the point of the year we did the quantification for the country. Next slide. So in terms of lessons learned, there were quite a bit, and some of these have progressed over time since then till now. So one of the things that we saw is that we need to allocate adequate finances to meet our HPT requirements and ring-fence funds for HPT. That has been an ongoing discussion from the national level. Of course, you'll never have enough resources to meet all the HPT requirements, but we need to ensure that budgetary allocations are guided by exercises like this. And I remember from each aggregation workshop, the focal person from the county went back with the aggregated report for their county to try and advocate for increased budgetary allocation from their counties. Then the other lesson is that we need to strengthen oversight for supply chain processes. There are many processes that will impact what is eventually procured, and we need to address each of them and the things that need to increase, things like efficiency. We need to look at issue of reducing wastage. You don't want to end up with expiries for what you have managed to procure, because we know resources are never adequate. And remember, even as we dispose, then you're still asking for funds to do that. So we need to make sure that our wastage and losses are very minimal, and whatever we procure is used for what is expected. We are not over quantifying and buying stock for things that are not moving, yet what is required is not adequately catered for. Then the other thing is continuous capacity building on HPT management. Remember, forecasting is just one step in the supply chain management. We need to make sure that the other processes that are complementary to even what we forecast and procure are also addressed, and there's maximum utilization of the resources we have. So that is continuous. Remember, human resource may keep shifting from one facility to another, so we need to keep constantly building capacity for those that are handling commodities, those making decisions for what should be procured, what should be budgeted, to ensure that there is sustainability in what we are doing. Then the other lesson was is what you call the county HPT units that are at county level to help ensure that health products are always available and their management is optimal. So at the time, we didn't have these units in place, but currently they are in place, and we work with them from national level to ensure that what they are doing is also addressing the issue of availability of health products. The other lesson is on the issue of digitization for the stock management system and the supply chain, so that we are able to achieve end-to-end visibility. That makes it easy to retrieve data. Even these FNQ exercises would not be too laborious if there was proper digitization, issues of data analysis, and even the report writing, whether it is at facility level or the aggregation at national level. Digitization would make the processes easier. Then the issue of automating is also pegged on the digitization, so that it eases the processes that we need to do data collection, aggregation, analysis, and subsequent forecasting. Next. So in terms of current status, and this is not exhaustive, but there's progress since then. Again, looking at the lessons we learned when we did the first national one after many years. So currently there are 17 counties that with recent FNQ reports. So we've looked at within the last 3 years, those with recent data, many of the counties still have the 2021 data. And as I said, we have 47 counties in Kenya, so you can see we still have some way to go. Because at national level, we are supposed to always have a national picture of what our requirements are. The other thing is that KEMSA, being our main procurement entity for public sector, use data from policy level to also guide their procurement. So it is imperative to have recent data that can be used to make decisions, whether it's to guide procurement or to advocate for more funding from our national treasury. It's very important for us to have that up-to-date data. But there have been efforts to standardize the methodology for quantification, looking at our lessons learned and recent FNQ exercises, because many times there are partners, implementing partners that are supporting certain counties. We don't have a partner supporting all counties on matters of the supply chain, but we need to also bring up the counties with the old forecast so that we're able to be at a similar level for all counties. So what we have done, and we are in the process of finalizing, is the issue of developing standard quantification tools. So we currently have a standard product list for counties and for national referral hospitals, so that whichever partner is supporting a certain county is able to access that. And remember, as I said, at national level, we need to have a national picture. So the aggregation of that data needs to be standard so that we're able to be looking at data that is helping us to make decisions. So that is the tool, at least, is there. And we've also developed standard operating procedures for quantification, again, given that they support from different corners, and some partners are going directly to counties, and we're not able to direct a partner to a certain county. So the standard SOPs will be able to guide even a facility. If a facility wants to have FNQ data, they'll be able to use the SOP so that we're able to have a standard way of doing the various processes. Then, in addition, there are job aids that we have also developed as we are reviewing the SOPs, again, to guide standardization of processes, and outputs are also guided for the country. We have what we call a quantification handbook, that is a 2020 document. But now, with the current updated SOPs, job aids, the tools and processes will be able to easily update that again for use by counties and any other stakeholder within the country for that. Then the other thing that we have done is, as I mentioned, the issue of aggregation of data at national level. So we are working on that even as we update the tools, as we engage different partners to also offer support to counties without support for FNQ. Then there are also efforts by the Ministry of Health to digitize all health facilities, to ease the manual aspect. And that was mentioned by Sylvia, and I'd mentioned it earlier, so that it eases the way we do quantification, eases the retrieval of data, analysis, aggregation. Yeah, so that will go a long way. That again is ongoing. It's not complete, but there's some good progress, and we hope even as we complete digitization of all county facilities and national referral, we'll be able to get there sooner. Next slide. Thank you, Sanjay, and yeah.
Yeah, excellent. Thank you so much, Dr. Gathitu. And I would request you to just stay for a little while because there are some questions already asked. And I have a few questions just to uh, tie all this up. But before that, I would like everyone to give a round of applause to Dr. Gathitu using this method. So, Dr. Gathitu, excellent presentation. And I would also like to make sure that all of our audience understands how complex this is. So just to paint a picture for everyone, and please correct me if somewhere if I go wrong. So, as Dr. Gathitu mentioned, Kenya has 47 counties. Okay. Now, procurement at a national level is managed by an institution called KEMSA. Okay. Now, KEMSA is not governed by the same charter the way the counties are governed. So, KEMSA in itself is a parastatal organization, although they are coordinated with the Ministry of Health. Okay. Now, then there is a team where Dr. Gathitu works, which is the DHPT team, Department of Health Product Technologies within the Ministry of Health. And similar teams are also now being constituted at a county level, which are directly under the Ministry of Health at the national and county level. Then there are partners, donor funded implementing partners. Some partners are working at a national level, some partners are working at various county levels, but not at all counties because there are 47 counties. Some partners are working at certain counties, certain county level. So now with this entire ecosystem, each county has to conduct quantification of the health product and technologies, products which are not funded by donors. So these products, these are directly procured by the Ministry of Health of Kenya. Okay. So these are not the donor funded products. These are not HIV, TB, malaria, reproductive health, or vaccines. Not those products. Okay. And typically these are more number of products because probably the program products are at max 100. These go into thousands. Okay. So now you can understand the complexity of it. Now, someone mentioned in the chat that there should be ELMIS. Yes, of course. But as you saw from Dr. Gathitu's presentation, I will go to that slide. Dr. Gathitu, please correct me if anywhere I'm wrong, because this is, I understand from the context of Kenya. Now, if you see here, uh, there are more than 7,000 facilities. These are public, faith-based, and of course, not counting many other private, because these are probably the only private facilities where they are buying from the county itself. Okay, if that is the correct assumption, Dr. Gathitu. But probably all the public facilities are counted here. So even if we count just the public facilities, that's more than 6,000. Okay. Now, if you want to implement a ELMIS system, which is end to end, that means ELMIS at a broader dashboard level should be at the Ministry of Health in the office where Dr. Gathitu sits. A similar interface should be with KEMSA for all types of products. Then at a county level, the county office. Then at all the hospitals to collect data, the same system, but with a data collection interface. And then the same system at each health facility to collect data. Now, I know for a fact that part of the work is ongoing in Kenya. KEMSA themselves had digitized their stock management system a long while ago, but you can imagine the investment and the time that it may take to cover more than 6,000 facilities or up to 7,000 facilities. It's a massive undertaking. So it is not always easy
I have a question.
to digitize the entire system. And this is where we must appreciate the work that is happening in Kenya, because they have taken that undertaking to digitize as much as possible. Now, another thing that you may have noticed here, that data was only collected from 800 plus facilities, not from the 7,000 facilities, which is the total scope. Now, why do you think that has happened? Now, this is one of the challenges that we uncovered before, that there is a data quality issue, there is a data collection issue. We don't have many people at the health facilities, and this is also mentioned by Dr. Gathitu, that we don't have pharmacists at many lower healthcare facilities within Kenya as well. And then it becomes insanely impossible to collect those data because they don't even know how to collect the right data. Hence, they selected those health facilities from where data could be extracted. So that is a workaround. Now imagine if all these facilities have an ELMIS interface and people are trained to collect data, which automatically feeds into the higher level systems and dashboards. Then Dr. Gathitu's team don't have to do sampling. They would have data from everything, and then analysis becomes even easier. Okay. So again, I just want to make sure that you understand the complexity of this process because Kenya is fairly a large country. For smaller countries, it is easier. For countries like Ethiopia, Nigeria, it is even more difficult. So that complexity has to be understood. Dr. Gathitu, have I summarized it correctly to a large extent, or have I missed a few points?
Very well. You've done well, Sanjay. Thank you.
Okay, excellent. Dr. Gathitu, couple of questions. One from my side, and then one something someone has asked. So you said in your assumptions, which is here, and I will again take, uh, yeah, here so that people understand. So you said that you've as a team you've taken an assumption that there would be a 10% increment uh, on the demand of these products. Now I believe when you were starting, uh, again, what I'm trying to ask is, did you as a team have some kind of a basis for this 10% increase, or it was just a starting point and now as you move forward you are changing that assumption that maybe it's not 10, it probably it's 12, or maybe it's 7 as you move to the next exercise and then try to extrapolate. So I just want to understand the basis of that 10%.
Okay, thank you. I think it was I don't know whether we looked at the economic growth for the country,
Okay.
but remember this was our first time we were doing it
Yes.
after I don't think we had ever done as a country before.
Hmm.
And the challenge with the non-program commodities is that there are very many, over 1,000.
Yes.
So comparing that with the strategic programs that some may not even have 100 products. So strategic programs are able to do theirs every year, given that these may be difficult to do, especially manually every year. So that was our start. But I know by the time we are doing another one for the country, then we may consider another increment, maybe not
Yes.
necessarily the 10%.
Yeah, because now
Yeah,
you have a data that how much was the change year on year. So you can take an average probably or a median for your next, and also looking at population growth, also looking at disease patterns.
exactly.
I know it's
Yeah,
very complicated, but that's the reality of it.
yeah,
Yeah, okay.
that's it.
Yes, again, Elizabeth is asking, did the 10% include population growth rate, inflation rate? Uh, all that was looked at, like Dr. Gatitu said, it was the first time that they were doing it. So it was an assumption. So that's why it's an assumption. As you go along, then you need to uh, make your assumptions more clearer and aligned to better data, and that is what they are doing. Dr. Gathitu, there was a question which was asked. I think it is also very important. Onesimus Namholo asked, how do you strategize your staff recruitment when considering your health products and technology development or specifically procurement of such needs? I think they're asking from a county level perspective, if I'm understanding this question correctly. Dr. Gathitu, over to you.
Okay. Yeah, so as I said, county level do are tasked with service delivery. So any hiring is done at county level. I would not be able to say that from a national perspective because that's not part of our mandate. But in terms of governance of health products, as I said, the county level has the county HPT units, and the guidance we have been giving counties is that that team has to be multidisciplinary, such that every commodity manager is handling their products. There are things that a pharmacist may not understand about lab, so you need a laboratory person to manage the products. So that's what I would say from a governance perspective. But of course,
Mm.
if you look at the broader human resource hiring, it's not necessarily pegged on um, filling the gaps for human resource based on the number they have. So there are other dynamics. But in terms of governance, we try to guide that every commodity manager that is relevant should be part of the data collection and the management for health products. Thank you.
Okay. Thank you, Dr. Gathitu. Gayatri is asking, I would rephrase that question slightly. She's asking what digital solutions were used during this exercise. Gayatri, I've rephrased your question a bit so that it makes sense with respect to this particular case. Dr. Gathitu?
Sorry, what was the
So the
question
question
again?
is which digital solutions were used during this exercise?
Okay. So in 2021, actually, the tool we had was in Excel. So data was being keyed in into the Excel. There were worksheets that were helping to do extrapolation, again, given the assumptions and the criteria we had indicated. But currently, we have progressed further. That time, as I said, we didn't have a standard product list. So we have developed one. We have put in data that we don't in the spirit of reducing data entry, there is data that is within the tool that can't be changed to ensure that the output is like standard when we are looking at aggregated data. But the other thing that I should have mentioned was that KEMSA has an LMIS system that they are currently using for to guide their forecasting as an entity. And in the updates that I had mentioned, we had a recent pilot in 10 counties that KEMSA used their LMIS for. But the difference from what I had presented earlier is that the LMIS tool that KEMSA is using is a sensors tool. So it is not looking at sampling of facilities. So data collection is done for every facility in the county. Of course, that has its challenges. If you're limited in terms of time and finances, that may be a challenge. But given the guidance that we want to give counties that we are finalizing, there'll be an option of either sampling facilities or doing a census. So we have progressed in terms of where we are at as of now. Thank you.
Thank you, Dr. Gatito. I think one last question. I think it's a quick one. Irfan Khan is asking, is your country using DHIS2 to collect data from health facility level?
Yes, so DHIS2 is our service data platform. As part of the efforts to digitize, DHIS2 is one of the platforms that will be part of our digital superhighway. It's not able to handle these 1,000 plus health products in it, but the issue is that there'll be different digital systems connected to the digital superhighway. There's the issue of interoperability. So you can, at national level, we can triangulate service data from DHIS and triangulate data from KEMSA, which is mostly consumption data. And we are able to relate on whether the service data is speaking to the consumption data. So the issue is that DHIS2 cannot handle all commodity management data. It handles the strategic program commodities, but not all the non-program commodities. The only thing that we have in DHIS2 is what you call a tracer list for non-program commodities. There are 85 products that counties report on every month. Uh, so there's interoperability as we talk about digital superhighway, and DHIS2 is one of our sources, especially for service data. I hope I've answered your question, the person who had
Yeah,
asked.
I think that answer you have answered the question, and I again would want to add this is another level of complexity, everyone, that while DHIS2 is there, it, it cannot serve for all the products. I mean, again, it may be the tool limitation, it could be because the tool has not captured all these products. So again, there are so many complexities when you do quantification. uh, we have only talked about HPTs. If we go into the program side of things, there are other kind of challenges, other kind of complications. And these complications never seem to end. So today, what we have tried to provide you is a logical and a robust pathway that you could use to make sense of what is happening in your country. There was a comment from Jimmy Aden, that Nigeria also has similar kind of problems, and Nigeria is also decentralized. They have states instead of counties; they call them states, and each state is supposed to quantify and procure non-program products, and again those products are very many in number, and each state has thousands and thousands of facilities depending on the size of that state. So it's a similar kind of problem in Nigeria. So today, what our attempt was to give you, first of all, a process flow of how forecasting and supply planning must be done. Then talking to you about challenges that occur globally, not just in Kenya. So the challenges that we have talked about, they are everywhere. It is not only a Kenya specific challenge, but they are happening everywhere. We just used Kenya as a case to show you that these challenges are reality. Okay. And then we also try to provide you certain strategies of how you can address those challenges. So first, Sylvia talked about those strategies theoretically based on her experience of supporting different quantification exercises. And then Dr. Gathitu talked about very specifically about the health product and technologies quantification that she has been part of within Kenya, that is done for all counties. Okay. I see there are other questions coming on the chat, and I would request please keep sending those questions. Unfortunately, we won't be able to answer them right now, but all your questions are being recorded, and we will compile them, put a response, and the document will be shared with everyone. So your questions will also be posted on the document with your name. So please, anyone, if you have any questions, please keep on adding into the chat, and we will compile them and send a detailed compiled Q&A document. Again, I would like to thank Sylvia and Dr. Gathitu. Uh, Before I go into the poll and the next section, I would quickly request both of our speakers and anyone who can switch on their cameras to switch on the camera so that we can take a group snapshot. Muskan, if you can remove the slides, and then as people come on camera, if you can take some screenshots of today's attendance. So we'll just spend about 30 seconds on this. So everyone, please, if you can switch on your cameras. So Muskan, you can take a few snapshots as people join in. I'm seeing many men. Why am I not seeing women? Okay, excellent. Nice, beautiful faces, everyone. I know many of you. So it's great to see you continuing with Be Skilled as we keep on bringing new things to you. Excellent. More and more faces. Very, very good. I see a few women. Excellent. I see an infant as well. Excellent. You are learning forecasting from very early on. You are going to be a rock star. Excellent. Okay, Muskan, are you done? Excellent. So we go back to the screen share. Thank you everyone for switching on your cameras. Um, Thank you, Douglas. And we would continue throughout this year. You will see more and more programs. You will see more webinars. You will see many other things. So thank you for your support. So with this, we go on to another poll. You will see that coming on your screen. I think it's a poll. We do the poll first. Yeah. So we'll do the poll first, and then I go back to a quick chat-based discussion. So this poll, um, is based on what you have heard so far, and we want you to identify one action that you would like to prioritize before the next round of quantification in your region, in your country, in your district, in your facility, wherever you are. So, one action that you would prioritize before the next forecasting, supply planning, or quantification, whatever that you might want to call it. So, there are five options. Please choose only one. Now, as you are coming out of the poll, there is a quick discussion. We will not take too much time on this because I want to move forward and complete this webinar, which is another 10 minutes left. I want you to type in the chat as many people, if you can, the challenge that you had chosen initially in the first poll, and then how do you think you would be able to address it. So if you can write that quickly in the chat, they will also be compiled, and we will try to share these responses with everyone as to what kind of challenges that you are facing. And based on this webinar, what do you think could be an action that will help address that challenge? Okay, so this is again on the chat. I will talk about this again and then I will move forward. So I want you to think about the challenge you selected in the first poll when we did it, or the challenge that you have today, and one action that you think would help you address that challenge before the next quantification exercise. Okay. So for example, I think Douglas has already written data quality issue solved by on-the-job training at the facility level. So excellent, Douglas. This is the kind of response we're looking for. But if you can, in everyone, if you can just make it a bit more explicit so that we understand what you're trying to say, do add the helping verbs here and there. Okay. So that's something on the chat that will keep on continuing until the end of the program, and we will compile everything and then prepare the report. Now, Muskan, is the poll done? Can we see some of the results? Excellent. How many people contributed, Muskan?
55 people.
Excellent. So you can see this is a good amount of data. And I think the winner here is map and organize all the data sources. I think if you can do that, everyone, I think it will solve many, many problems within your quantification. Okay. The second point which was selected was clearly document all key assumptions. And you are absolutely correct. I have seen many quantification exercises, and a lot of times assumptions are not recorded, they are just in the analysis. And then I'm asking, so how did you arrive at this point? No one knows because they don't even remember what assumption was being used. So I think if you focus on these two things, mapping and organizing all the data sources and clearly documenting uh, all key assumptions, I think you will be able to solve many, many quantification issues in your next exercise. So very quickly, let us move forward with the final segment of this webinar. Okay, why is it not coming? Okay, yeah. Now, this is the supply chain framework, which some of you may have seen if you have gone through our Collective Learning Certificate 1 Supply Chain for Health program. This is what we use to showcase the entirety of supply chain. Yeah, this is the full framework. So as you see, quantification is at a very critical juncture. If your quantification is not correct, it will affect a lot of things. It will affect your procurement, it will affect your warehousing, storage, transportation, last mile. It will affect your quality management, it will affect your financing, it will affect your data, it will affect almost everything. Hence, what we need to understand is that quantification is a very crucial and a critical activity. And being supply chain professionals or pharmacists working at a district facility or hospitals, wherever you are, you must know how to manage quantification, whichever level that is. Dr. Gathitu is doing it at a national level, hence it is very complex. As you keep going down, at a county level, it is much less complex. At a district level, again, much less complex. At a facility level, much less complex. But the process remains the same. The process does not change. And hence, everyone needs to understand the process of forecasting and supply planning. You need to have the right skills and knowledge of the entire process, so that you can apply that knowledge and skills to set up, establish a more sustainable process to ensure steady supply of health products. And this should be non-negotiable. Okay. So we learned that there is a skill issue. We learned from Dr. Gathitu as well that there are many non-pharmaceutical staff at health facility level, and even many pharmaceutical staff at various levels. Even they don't have a full understanding of how quantification or forecasting and supply planning works. And hence, the course that we have, forecasting and supply planning of health products, developed jointly by InSupply and B-Skilled. This is a course that helps you to develop those skills in a more holistic and comprehensive way. So these are some of the learning outcomes from the course. Uh, if you go through the course, you should be able to describe the need for effective forecasting and supply planning, demonstrate the critical requirements for effective quantification, apply various forecasting methodologies to prepare periodic forecasts, describe the process of supply planning and how time, budget, and space affects it, and finally, be able to prepare forecast and supply plans for health products. So, what you learned today in the webinar, the course provides you with 100x more of knowledge and skills, and it is designed in a way so that you can go and start applying very quickly. There is no lead time between you finishing the course and then thinking how would you apply it. The course is designed in a way that helps you apply what you learn very, very quickly. So this is the course pathway. There are 6 modules at various levels. There will be live sessions if you join a cohort, or if you join a self-paced learning, then live sessions won't be there, but you will get access to the previously recorded live sessions. So at different modules, there are formative quizzes, as you see the orange bars, and then there will be a detailed exercise under module 6 where you will be able to see how logic is applied at forecasting and supply planning. And we work with Excel tools, and we also showcase some other tools quite often on how you use them to prepare your forecasts. And then you go through an assessment that results in a CPD certified, CPD accredited certificate. We have global accreditation. We also have national accreditation so far in Kenya and Tanzania. So if you are from Kenya or Tanzania, you get national credits, but everyone, irrespective of wherever you are, you will always get the international accreditation that is associated with this course. Um, we have some people who gone through this course in a cohort format, and they have said some beautiful things about this course. So from Nigeria, so all the 3 people are from Nigeria because the cohort had more people from Nigeria. And if you see what they're talking about, they are planning to apply these skills. They're saying they will use it to prevent stockouts. They're saying that each module contributed to a better understanding of forecasting, supply planning, and also overall supply management. Okay. They have been able to strengthen their analytical and planning skills through this course. So just want to reiterate the fact which I was saying before, that this course is designed from a practical point of view so that you as professional get practical skills which you start applying right after completing your course. So there is a QR code, you can scan it. The course fee is very pragmatic. You can start the course just by paying an enrollment fee of USD 20. And depending on where you are, you can also pay in local currencies through mobile money and other avenues. So you need to reach out to our team. Then once you complete the course, okay, once you complete the course, you've paid 20. Once you complete the course, you can then decide whether to receive your CPD certification or not. And hence, if you pay $100, you get your CPD certificate, or otherwise, you have anyways completed the entire course and received the practical skills that we are talking about. So, this with $20, you get 90 days of access. The course is accredited by the CPD certification agency in the UK and also by the PPB, Pharmacy and Poisons Board, and the National Council of Kenya, and also in Tanzania. They are accredited as CPD. Like I said, there are 6 modules. You should be able to complete this in 4 weeks, more or less, depending on how busy you are. But if you spend 3 to 4 hours a week, you should be able to complete this in about 4 to 5 weeks. But you still get 90 days of access. Once you complete the course fully and you get certified, you retain access to the course for lifetime. So you can come back anytime and refer to the materials. You will always have the access of the course. So the QR code is here. If you want to register today, you can do that. The course is open. Right now, many people from various African countries are already going through the course. In fact, some people from Europe are going through the course as well right now as we speak. This course has, we are also training Europeans in this course. But the course is more specifically designed for people in Africa or other emerging countries like in Asia or South America. Okay. Currently, the course is in English, but we plan to translate that in French in the coming months as well. Okay. So this is the course. I will now quickly move on to just a summary of this webinar. I'm just checking if there are any questions about the course. Okay. Someone is asking if there are free certificate courses. Yes, absolutely. If you join the Hive platform, you will